Good evening, everyone. Here Imran Abbas. Again, we are live. I am live from Dubai, and today we have Professor Antonio Torres from Spain. It's great honor to interview such a great figure. No doubt, Professor role for promotion, for, in my opinion, sharing knowledge for bariatric and metabolic surgery. We all know decades he's doing his best, especially for promoting education. And everywhere you can see Professor Antonio Torres is there now, 2 days in Brazil, here in India, here in Spain, everywhere. If so, everywhere. He is a dominant personality, and it's great honor for me to interview such a prestigious figure. As my viewers, you know, we have started this interview series with MGB, OAGB, that was for 6 months. Then safe sleep gastrectomy as well for 6 months, and Roux-en-Y gastric bypass. Now we have started this metabolic surgery in low BMI diabetic patient. We have started this series with Professor L. Perchelek and continue with Professor Surendra Ugale, C.K. Huang, and many. And today it's great honor. I am with a live legend, Professor Antonio Torres. Sir, so much thanks for accepting our invitation. And at GLR platform, as you are also faculty of GLR, just GLR, Global Laparoscopy and Robotics, and it's also again an honor for us. Sir, over to you, sir, please.
Yeah, well, first of all, thank you very, very much for allowing me to share with you this interview, this live, documentary, I would say, focus on metabolic surgery. My name is Antonio Torres. I'm a professor of surgery at the Complutense University in Madrid, and I was a past president of DIPSO. I have been performing, bariatric and metabolic surgery later on since early 80s, the last century, 1980, 80 something. We were starting performing open scopinaro procedure those time back then. And then, we went, through all the different approaches, all the different improvement, and all the different new knowledgement that we already got during the last years. At present time, we are performing our procedure at the Complutense University in our Department of Surgery, where we have a very huge, department, section focused on upper GI and bariatric and metabolic surgery with the multidisciplinarity, and also in my private practice at the Hospital Universitario Monte Príncipe, also here in Madrid. But anyway, I am here open to all your questions. I hope, we can fulfill all your doubts, all your interests, and all your inputs.
Sir, so much thanks, and really it's great honor, and I'm excited to interview such a person who has experience of bariatric metabolic surgery about 4 decades, and definite from the open surgery era till this robotic surgery, and this is a journey of bariatric surgery, and he experienced himself. And definite today we will have a lot of questions also myself and from my viewers. And it will be, in my opinion, one of the best session. Sir, we have divided these questions in 3 parts. In first part, so we will discuss about patient selection, especially diabetic patient with low BMI. Then we will touch about technical points of your specific metabolic surgery technique. Then in third session, we will talk about your results. Sir, first, that is the most important in my opinion, is patient selection. How you select your low BMI patient for metabolic surgery? What is your criteria?
Okay, well, Dr. Hinram, we have to take into account now. Let me share my computer, my screen, because
yeah, sir, you can share. You can share. I can see.
I'm sorry, I'm not sharing this one. I will share another one. Still sharing. It's another one. Just to comment on you, the different, strategy that we have regarding selecting those kind of patients. And here you can see, the new updated line guide that we will have be published in this October, latest October and November, putting together the two most important societies all over the world. I mean, SMBS and IPSO, they got an agreement in terms of updating the old guidelines. We have to take into account our old guideline coming from the National Institute of Health in 1992. Now, we were saying that all the patients with BMI more than 35 can be, included in this bariatric metabolic surgery, but also we are going to deal with BMI patients more than 30. It's going to be a very important step forward in terms of getting those patients there. Until now, we select the patient with BMI over 35. But now, this is not really true because we, in our clinical practice, we also operate in patients over 30 BMI with type 2 diabetes, not well-controlled type 2 diabetes, and other metabolic comorbidity, mainly dyslipidemic and hypertension in terms of the risk of the cardiovascular risk of this patient. But as you can see here, there is also an agreement in considering the Asian population with a BMI more than 25, focus in this scenario. So I think, this is the new scenario we are going to face in the next years. I guess, in my humble opinion, it's going to be this paper, they are going to be published the same day, in the same number, in SOAR and in obesity surgery. It's going to be a very important step forward for, leading the indication of the new metabolic patient. I'm going to stop sharing now, just to
sir, excellent. And this is the good news, in my opinion, especially for Asian people, Asian patients, because in Asia, especially in subcontinent, the main issue is central obesity. And that is definite. Maybe in future, the people like you, so you will change also BMI to another criteria, like maybe this is that we as the circumference of waist may be more important in future, maybe, and that will be criteria as compared to, but still BMI is a selection criteria, and this low BMI, especially 25, will helpful for those patients who are only central obese but suffering with diabetes. Sir, regarding your lab test, so if just now, just imagine in your country patient with 30-31 that included with metabolic syndrome or diabetes, which tests are important to do before surgery, and you can predict the result of your surgery?
Yeah, of course, we have to be sure that those patients between of the low BMI are really type 2 diabetic patients. I mean, we have to exclude the LADA positive, the LADA patient. I mean, the Latin autoimmune diabetic in adult patient. We have to exclude that, and we have to be sure that the glycate, the hemoglobin A1C is going to be, in a wrong range. And for sure, we have to be sure that we are dealing with type 2 diabetic patients. So we indicated mainly in this low BMI patient, our surgery, in those patients, metabolic syndrome, not well medically controlled. I mean, type 2 diabetic patient with not very well controlled with medication. Dyslipidemic patient also in this sense. And it's going to be very important to be sure that we are dealing mainly with type 2 diabetes patient and low BMI. Nevertheless, we already have operated some very selected type 1 diabetic patient with overweight, just in terms of trying to improve their quality of life, in terms of decreasing the number of insulin units that they need. But those patients, even we already published this paper with a very selective patient with type 1 diabetes, it's going to be in an important agreement with the diabetologists and our endocrinologists. Very selective patient, very well informed patient, and probably in some of those patients going to be worthwhile. But our main test before indicating the surgery going to be, the hemoglobin A1C level, and excluding the LADA, levels in terms of avoiding to be facing with type 1 diabetic patient.
1.5, yeah. Sir, excellent. Sir, so this criteria, so when we ask, so this is a poor control diabetes. So what is the definition? So how long time we can wait, and when we can ask, yes, this patient is poor controlled, so it's not controllable.
Yeah, it depending. If you are facing with a patient with a lower BMI, probably you have to wait a little bit more. I mean, in terms of putting the patient on insulin, diabetologists and our endocrinologists, they already will put our patient on insulin. Differently, the patient with a higher BMI, in those patients where the weight loss is also essential in their management, we don't wait until they need insulin. We indicate surgery before they need insulin. But it's different. In the patient with a higher BMI, they don't wait. In the patient with lower BMI, they wait in terms of focusing in controlling types of diabetes, especially now with the new medication they have. I mean, GLP-1 analogs and all these medication they are having now going to be to delay a little bit, the surgical indication for sure in the next years.
Yeah. So regarding this, so to rule out beta cell reservoir, is it necessary to check the C-peptide?
Yeah. We already checked the C-peptide in terms of getting sure that the beta cell function is okay for sure. So the indication going to be before the C-peptide when it's so low.
Yeah. Then we can predict. So then we can talk with the patient. So yes, this will respond to this surgery because you have sufficient beta cell reservoir. Regarding
absolutely.
LADA,
We have the information now. We have the data that the patient that has been under insulin with a lower C-peptide level, the long term, their clinical results long term are worse than those patients with a better beta cells function.
yeah, definitely. So regarding LADA, that is also a challenge, especially in thin patients, because when we must rule out this autoimmune impact, because if we will not rule out this one, maybe this surgery will not respond. So what is my question? In low BMI, are you rule out this LADA in all your patients or no? Some patients, yes, this.
No, in all our patients. Below
All.
BMI patient, we do in all our patients.
Excellent, sir. Sir, now we will be in technical points, and I am interested to hear from your side your technique. If you have any video, if you want to share any slides, I will be happy.
Dr. Imran, I'm going to share, my screen again. Let me. Please, here you can see, just to to be aware that the SADIS technique, the principle of the technique, you can see here this drawing that only very nicely, gave by Caetano Marquesini from Portugal. The principle of the procedure is going to be, how to be not very restrictive. We perform a sleeve gastrectomy over a bougie of 54 bougie. It means 1/8 millimeters bougie. And at the beginning, don't be very restrictive, and to preserve the antropyloric area is going to be very important in our opinion. And at the beginning of our first 50 cases, we performed anastomosis. The common channel was the 200, but we shift 250, our standard length of our common channel now. So I'm going to be the most important landmark, but mainly, known to add a huge restriction, a narrow sleeve, to an hypersorptive procedure. So here you can see, after this video, I hope the audience cannot have fear about the duodenal dissection. Fear of the duodenal anastomosis also non-consistent. And here you can see our surgical technique. Here you can see a clip, showing a different aspect. Yes. Here you can see the way we perform the sleeve gastrectomy, a part of the procedure, and then the surgeon changed to the other side. Regarding the sleeve, I don't want to stop here too much. We use ultrasonic energy because all of you know how to do that. The most important part is, how we perform the distal dissection of the duodenum, as you can see here. We go, the secret, the strategy is to be very close to the serosa of the duodenum and the stomach. I'm trying to get to the duodenal-pancreatic angles. Here you can see very close, very close. These devices, the ultrasonic energy is very nice. We have to go very, very close to that in terms of performing a circumferential dissection of the duodenum. Here you can see how we do that. Here you can see the pancreas here. This is the pancreatoduodenal groove here. You don't have here. You will see. The gastrointestinal artery is not going to be mandatory to do that. We perform. This room here. We pass a tape right here. We perform. We don't do the sleeve until we perform our duodenal dissection. Then after finishing the sleeve, we divided the duodenum as distally as we can. We also divide, here you can see the bile duct going to be this way. This is the importance of introducing the stapler for the right side of the surgeon in between the legs or the left side of the patient. We put a Barbie suture in the upper part of the duodenum, then we count our bowel from down to up. And then we put down, these Barbie 3 stitches between the duodenum and the ileum that we already pull up, to maintain that there is no tension. We don't divide the right gastric artery, and we perform a 2-layer anastomosis in a very nice way. We were performing the anastomosis between the small bowel and the small bowel. This mucus is pathognomonic of the duodenum, and again we do the posterior row with 3-0 Barbie suture in a there is no tension, very nice blood supply. It's going to be very well performed. We don't close the mesenteric defect. Here you can see our final, row. We check our anastomosis with the methylene blue. And here you can see how we check the stanquity. There is another option, we can do robotic, regarding the dissection of the duodenum. This is the robotic duodeno-ileal anastomosis. Again, you can gain the third dimension. Again, the mucus is here. We are performing the anastomosis hands-on, also by the robot, using again 2-layer Barbie suture and in a very comfortable way with the surgeon seated at the console. Okay, here you are, the way, again, 3-0, the stitches the same way you saw previously. We also have other approaches. Here you can see how the robot is performing, the surgeon with the robot is performing a very nice anastomosis between no tension, very nice supply, anastomosis wide of 2.5 centimeter. This is the anterior layer, again 3-0, and then the last one we do interrupted stitches from PDS 3-0. Again, there is the surgeon, the audience doesn't have to fear, to have some concern about this anastomosis. Here you can see completing by a robotic approach. Again, we can also perform the anastomosis stapler. It's another option. Here you can see we put together the duodenum and the ileum, and then we open up a little hole. Again, the mucus here, pathognomonic, we are post-pyloric here, is the Brunner glandular secretion. Here you can see we make a hole here, and the duodenum and the ileum, we introduce the stapler. We introduce maximum 45 length of the jaw of the device. Yeah, here you are putting 45. We also put 30 millimeter, depending on the stapler you are using. It's a Signia or it's an Echelon device. Again, the anastomosis is 2.5, 3 centimeter. We fire the device, and then we have to close this hole again in a 2-layer fashion. This is another option. You can do hands-on, you can do robotic assisted, you can do a stapler, though in the end, you don't have to be afraid about that. Don't have any fear about that. Again, you can also hear how safe we are closing that in a stapler. And again, we check our anastomosis with methylene blue. And also here you can see the outlier, the last layer, interrupted 3O PDS, just to decrease the tension and to have a better view of the anastomosis. Also, we are now, having some help regarding the indocyanine green, the ICE, regarding how to check. Here you can see the right gastric artery here, showing that non-divided, the right gastric artery here can improve, right? You can see here the right gastric artery, how we can maintain the blood perfusion of the lesser curvature, even we don't damage the vagal nerve branches in this area. So it's another help we already have in this scenario. And now recently we are doing also magnetic anastomosis with Michel Gagné, and also it's going to be a next step probably. I'm going to stop sharing. I hope this little step.
Amazing. I think so. This demonstration was completely, and hopefully my viewers also they understand. So how you do SASI, and especially that was first hand sewn. That was amazing, because just that is end to side, and this is end to loop, and hand sewn definite is less risky as compared to, because stapler again need little tricky. Personally, I did some, and unfortunately, my this duodenum part become cyanotic, and really that was fear. I remember that week, so I could not sleep. So what will happen with the patient? So definitely, this is little trick, and this hand sewn amazing. Sir, regarding, so this is one question, a little maybe political question. So which percentage of your bariatric surgery numbers belong to SADI technique? If you are doing 100 cases, so how many cases you are doing SADI?
Let me share again, the screen, just to show you our, our case mix. Here you are. Let me share a little bit, and we perform now. Here you see our case mix. We are performing, in our department, 44% sleeve gastrectomy as a first step for SADI, or a definitive or one-shot bariatric procedure. And we perform almost the same number of SADI procedure and Roux-en-Y gastric bypass. Now we are increasing the SADI's number due to the increase on revisional cases after failed sleeve, and also after failed Roux-en-Y gastric bypass, or after failed banding. We are converting all these procedures in SADIs for weight regain or for reappearance of the comorbidities. Here we don't do this kind of procedure with anastomosis, up the pylorus. We prefer perform our anastomosis procedure below the pylorus, because we think that we are more physiological maintaining, the antropyloric area. We don't perform SASI, we don't perform SAHIs, and we don't perform one anastomosis gastric bypass.
Sir, so you have a pioneer of this technique. There is no doubt. So my question: what is the contraindication of SADI? What do you think this case is not good? If patient is suffering with GERD, and also esophagitis type B, and Barrett esophagus, so like this, or hiatal hernia, so which case is not good case for SADI?
The cases you already mentioned are not good for SADI. The patient have some esophageal problem. I mean, esophagus grade C, D, or Barrett's esophagus. Huge hiatal hernia is also a contraindication. No contraindication, non-indication.
Yeah, not good case.
No indication. But overall, not to offer a very powerful hyposorptive procedure in very low BMI patient, in non-very metabolic patient. If the patient is not very metabolic ill, I mean, there's no diabetic, not dyslipidemic, no hypertensive, no large BMI, we don't do SADI procedure. We perform in this occasion Roux-en-Y gastric bypass or sleeve. I mean, The ideal patient for studies are heavier patient, BMI around 45, 50, and very metabolic patient. And in those patients with lower BMI, if the patient is very metabolic, we increase the length of the common channel until 300 or 350 or even 400. We want to have a very powerful metabolic procedure for this low BMI patient.
Sir, in these cases, are you measure whole length of small bowel or no? Only common channel is sufficient for you, and there is no issue how much is BP limb.
Absolutely. I think the key is to know the common channel. This is a very important lesson we learn from Nicolas Copinaro, Douglas Hess, Picard Marceau, all the duodenal switcher BPD guys. The important thing is to know the length of the common channel. We have information about the revision of Rowan-White gastric bypass by Kelvin Higa and Enrique Maria, how the total length of the total alimentary length, is 4 meters, because in those patients, they had associated a huge restriction because the pouch in this American way of performing Rowan-White gastric bypass was very small and very narrow.
Yeah. Sir, one question, because your SADI is not like OAGB, but just so this is post-pyloric anastomosis, duodenal-ileostomy. But in one anastomosis, gastric bypass, just 3 to 4 centimeter before pylorus, we are doing gastrojejunostomy. What is the benefit of this SADI to OAGB? What do you think regarding marginal?
I think there is no doubt that the theoretically is more physiological because we are performing anastomosis after the pylorus. There is no doubt. What are going to be the advantages? For sure, there are some of them. In the OAGB, even the different teams say that there is no bile there. The bile is there. Probably it's transitory. In the study procedure, we are preserving all the vagal innervation of the lesser curvature, so the function of this area is going to be very important. We are going to have less marginal ulcer for sure. We're going to have less dumping, less hypoglycemic hyperinsulinemic syndrome, less abdominal pain. This very common abdominal pain after Rowan-White and after some OHB patient. My thought about that is, guys, I think, to perform the anastomosis more distally is, without any doubt, more physiological.
Sir, no doubt. So this chronic abdominal pain in Rowan-White are in some cases of OAGB due to bile gastritis in remnant stomach, and especially in Rowan-White, this is also a challenge. I understand, because when you will do a wide sleeve gastrectomy, there is no remnant, and also there is no definite that fear of any pathological finding in future in remnant. And also, and sir, I have one question regarding, because also you have highlighted about SASI, and you are not doing SASI, but definite at the globe, especially in Middle East, as you know, especially in Dubai, I am sitting here, so hub of SASI, and personally also I am doing. What is my question? Maybe in future, because you are innovative person, you think about this loop duodenostomy without stapling the duodenum, especially in low BMI. Is it possible?
Yeah, absolutely. The concept of the bipartition is possible. The only thing, if you are to treat in terms of getting a greater metabolic result, to define how much food or how much content going to be through one way or the other, regarding the SASI. And going to be, and also you will perform a duodeno-ileal bipartition. In the end, is to perform the duodeno-ileal anastomosis lateral without dividing. It's a nice and attractive idea.
Yeah.
But an important issue regarding this one is you do that in the bipartition, duodeno-ileal bipartition, you're going to be much more easier to convert in a complete studies. You know what I mean? Because we can do dissect posterior to the anastomosis and do the complete study. But it's a very attractive idea for sure. Even now we are working in magnetic surgery. We're performing endoscopically and laparoscopically a duodeno-ileal anastomosis. Lateral, maintaining the concept of the bipartition, going to be duodeno-ileal bipartition, and we have to do research on that. And in low BMI patient, maybe going to be enough.
Yeah, sir, because when we do routinely this bipartition, because typical bipartition, not loop bipartition, that most of our metabolic surgeons, they are doing bipartition like Roux Y. This is not Roux Y, but just to understand what I am asking. And this is a transit bipartition or sleep bipartition, different names, but bipartition, what is the issue in these cases? Because the gastric pouch size is bigger, there is more acid production and more marginal ulcer as compared to loop bipartition, because in loop there is bile and the buffering effect of bile, there is less chance of, theoretically also and personally also I see less chance of marginal ulcer. But if we do that, your procedure, duodenum, because duodenum is physiological small bowel, and
Yeah.
because there is less chance of direct exposure to gastric mucosa as well as gastric acid, because we have still pylorus there, and there is definite. I will talk also about your results. So maybe if you do this bipartition or loop or simple, and definitely it will be more effective. So now in this part, I am interested to hear more about your results and your post-op. In your patients, how long time you are following your patient, especially these diabetic patients, with this procedure?
Okay, let me share again, my screen, in terms of sharing our result on this. Regarding that, we are here. You can see our paper, showing the different result 10 years after the operation. Here you can see that our patient, we follow very nicely. Where a patient are a very heavy patient, a very metabolic patient. Here you can see 46 BMI medium, and 101 diabetic, 91 hypertensive, 81 sleep apnea, 118 dyslipidemic. And here you can see our follow-up is going to be very important. 10 years follow-up, 75%. It's a huge number. It's a very important piece of information, because the strictly is our multidisciplinary team, our endocrinologists are our main support regarding that. That's true that we lost some patients between 5 years and 10 years, but still 75% is essential. We follow more strictly our metabolic patient, not only type 2 diabetic, but all of dyslipidemic and also hypertensive patient. And here you can see here the percentage of failure after 6 years is increasing a little bit, but less than 6%, maintaining the result regarding total weight loss at BMI. And regarding the type 2 diabetes, here you can see we follow 10 years, 101 patients. The mean duration of their diabetes is very, very high, 9 years. 9 years. The patients were under insulin 41%, under anti-diabetic oral therapy 46%, and on diet 11%. And our result with a patient with no treatment, with hemoglobin A1C control 5.5 and 104 milligrams of glucose fasting level, going to be 76%. 17% were under anti-diabetic oral therapy and 7% under insulin. 10 years, the standard labs of the treatment, only 61% were with no treatment, 27 with oral anti-diabetic medication, and 11 from 7% were again under insulin, with a very acceptable figures of glucose plasma level 117 and hemoglobin A1C. But again, the most important finding in our long-term patient was not only the quantity, but the quality. Maintaining this antropyloric area, maintaining, preserving the vagal innervation of the lesser curvature, allow us that the glucose variability doesn't exist in the SADIS patient. We monitor the result 7 days in a row in this number of patients. We studied 12 patients under Roux-en-Y and 12 patients at the SADIS with complete remission of their type 2 diabetes. We submitted them with a continuous glucose monitoring for 1 week. And we observed that the patient with hypoglycemic events, glucose level less than 70, was worse in the Roux-en-Y compared with the SADIS. And the patient with the normal range was better in SADI compared with the Roux-en-Y. And the patient with hyperglycemic events, blood glucose level higher than 140, was worse in the Roux-en-Y patient. This is going to be, but this result has been, reproduced by other authors. Here you can see the student Migrone, the endocrinologist working with Francesco Rubino. They reproduced this result showing that the SADIS is going to be more similar to EPD regarding their metabolic effect, and the sleep gastrectomy more similar to the Roux-en-Y gastric bypass. You're going to be submitted to the patient with a test meal test. It's going to be important to take into account these numbers. Answering your question, we follow our patient 10 years, 75%, and we try to follow our patient for life, all the patients.
Sir, excellent. Sir, excellent. Excellent results, definite. And sir, in your study now more than 1 decade, you are doing SADI and also you are following your patients. So which percentage of your patients are suffering with marginal ulcer? Have you any patient?
No patient, because we don't have ulcer. We had one patient with acute bleeding after the operation, but probably going to be some, tearing of the anastomosis. We control the endoscopically. We put some argon there and some adrenaline there, and the stop. We don't have marginal ulcer.
Sir, are you prefer to use your patient any like this pantoprazole or omeprazole or something, so to reduce
we do in a systematic way. We do for 3 months. We protect them with PPI, and depending of their symptoms under control, we stop them in a very step-by-step way later on in the post-operative, in the follow-up.
Yeah, sir, one of the issue after gastrojejunostomy or gastroileostomy, any type of gastric bypass, so smokers are always challengers. So we prefer to quite smoke or something like this. Is also same in SADI procedure?
Yeah, we try to convince our patient not smoking, not only for the duodenal ulcer, but the marginal ulcer, but also for the lung cancer and the bladder cancer, But we try to do that, but we are not very, strict, I would say, regarding denying the procedure for those patients for being a smoker, as you can do with the Roux-en-Y gastric bypass. If you operate a patient, heavy smoker, and the patient is not going to stop, smoking, I think you must not, indicate on him or her, the Roux-en-Y gastric bypass. I don't know the one anastomosis gastric bypass. We don't have enough information yet regarding that.
Yeah, definitely, sir. In one anastomosis, gastric bypass also, we face such a situation. Sir, regarding this internal hernia, so that is also a definite concern in Roux-en-Y, especially Roux-en-Y gastric bypass. But in one anastomosis, as you know, we never close the defect. Is same policy in SADI?
Okay. I have to admit, we don't close the mesenteric defect in our department for sure. But if I operate it outside home, if I go to your hospital to operate the patient static, and you ask me, Dr. Hiram, you told me, Dr. Torres, why you don't close the mesenteric defect? Just in case you have some problem in the future, I will close in your hospital, just in case to avoid. But I must say that to close the mesenteric, the mesenteric defect in a SADIS patient is not easy. depending of the position of our trocar for operating the patient. Sometimes, if you want to close properly this defect, you have to put an extra trocar lower in terms of bringing up, the momentum and to identify the mesocolon. But, you can do that. Some teams do. We don't do in our department, but when I go to different hospitals, I do. I do after the request of the surgeons over there.
Yeah. Sir, one of the concern, my personal concern in this duodenal because as also you show your video, so you never dissect more, and definitely your duodenum is not ischemic. But when this is in anatomical position and you will attach this loop, this afferent limb is little kink, and when patient will so take food, it will go to afferent loop, afferent limb. Am I correct?
No, it's not a problem, at all. Some teams, the Dan Cotton in Utah, in US, they put a stitch between the afferent loop and the antrum, in terms of maintaining, the best way. But I don't think so, because it's another advantage of don't dividing the right gastric artery. This non-dividing the right gastric artery maintain the duodenal fixed without, and then, the anastomosis can be adapted to this situation. So we don't have this kind of problem. If you think you have some, wrong view, you can perform this kind of stitches, from the afferent loop to the sleeve or to the antrum. I mean, in terms of maintaining to avoid some twisting, but it's not going to be a problem.
But because I see some videos of internal ileal interposition, so they completely release this area, and also this stomach with duodenum are in straight position, and also there is no issue, no ischemia, blood supply is sufficient. Have you also any experience?
Yeah, we don't do that because these guys already in their position, they perform anastomosis inframesocolically. They open the mesocolon and perform, different anastomosis there, downwards. We don't do that, but we have information probably that regarding the blood supply, and even now we have the help of the ICG, in terms of checking the blood supply of the stomach. But we have information many years ago. The professor, the now retired Professor Caetano Marchesini, the father of the Caetano Marchesini, they demonstrate, very nicely how the left gastric artery is able to maintain all the blood supply of the stomach. But anyway, we prefer not just only for getting a better blood supply, but also in terms of avoiding damaging the vagus nerve, because we don't know yet how important is the vagus nerve over there. We have to, it's a hidden, it is the hidden protagonist there, because we don't know how we're going to be the innervation and the connection between the brain and the gut. It's going to be very important in the future, right?
Yeah, definitely, sir. Sir, regarding Sadi, so another question regarding in redo surgeries, patient after sleeve gastrectomy and weight regain, especially because maybe in GERD and also in reflux, this procedure will be not standard or good procedure, but in weight regain, only in weight regain cases. So are you prefer to do this surgery, and how much in such a situation must be common channel?
I think, in this situation with weight regain or, reappearance of such comorbidity after a sleeve, first of all, you have to be sure that the sleeve was correctly performed. We do in all the cases CT volumetry regarding, having analyzing the shape of the sleeve and say that, that the sleeve is going to be correctly performed in the first operation. If the patient, we have to take into account the initial BMI. The patient before the sleeve was a very heavy patient, I mean, around 45, 47, we do studies 250. If the patient before was not so heavy. I mean, around probably going to be most advisable to go 300 is what we do.
Yeah, excellent. Sir, regarding some results, so because I am also interested to know about, have you revised any SADI due to any complication?
Yeah, sure. We already have revised some patients, as in any surgical procedure. Those surgeons that say that there is no problem, no revision, they are lying.
Yeah.
We already have, sometimes we made some mistake at the beginning measuring the bowel. We performed anastomosis too close to the ileocecal valve. In those cases, we dismantled the anastomosis and go higher. We also have problem with we didn't do the proper selection. We have some couple of homeless guys. We didn't identify them during the World Cup or the MDT, and we have to revert the procedure. And we have a couple of patients with some technical problem regarding some anastomotic problem. In one case, we know the anastomosis was blow up, and then in this case, we dismantle anastomosis, we convert the patient to Roux-en-Y gastric bypass. The majority of our revisional studies is going to be in terms of not controlling, the hypoabsorptive procedure because some problems of the patient. And then in those cases, another important positive thing for the studies is its versatility. It's going to be very, very easy to dismantle the previous anastomosis and to go up even until the jejunum, performing what I used to call proximal studies. It's from people from Taiwan. Dr. Wang do that, the duodeno jejunostomy. Wei Li and all the Taiwanese guys and Japanese, Kasama, are doing that. It's proximal studies in the end.
Yeah, definitely. Because in those cases, maybe they will not tolerate such a hypoabsorptive surgery. So definite, they need more common channel. And sir, regarding this micronutrient deficiencies, because that is also another issue, especially any type of hypoabsorptive. And definitely you prefer to supplements for your patients. How long time you prefer these supplements?
I think we learn at the time went by that we have to increase the doses, the supplementation of calcium and vitamin D in terms of avoiding the pseudo hyperparathyroidism, pseudo hyperparathyroidism we had in the beginning. We almost double our doses in our study patient compared to the Roux-en-Y gastric bypass patient. Focus on the calcium and vitamin D, and also we push or we request our patient that they have to eat at least 80 to 100 grams of protein per day. It's going to be important to eat proteins and to get quarterly supplemented. The main way of getting that is to have a nice follow-up.
Yeah, definitely. Sir, what is your main concern? Now more than 1 decade, so you are doing SADI procedure. So when you do this SADI, still you have this concern, maybe this will happen like this, still. So definite, after this long time follow-up, a surgeon also have some concerns about this procedure, need to change, or we have still this concern, need improvement. So what's your opinion?
I think, we already improved a lot regarding the surgical technique. At the beginning in 2007, when we started, we started doing only a stapler anastomosis because we didn't have enough skill, to perform hands-on. I think the progression, the technology, the ultrasonic energy, the stapler, the way we do the vision, all the camera, 3D emission, robotic. This is going to be a huge improvement of the result and the confidence of with our procedure. Now, I would say 5 years ago, we scheduled one study in the morning. Now we perform 2 studies, one way. The technical point will be essential. The second thing we learn is how important is to commit the commitment of the patient with the procedure. How important is that the patient be aware of what is going to be in their bowel. And the third important lesson we learn is the importance of the multidisciplinary team in attending this kind of patient with liposuction procedure. Not only surgeons, endocrinologists, but also nutritionists. Very, very important. And, that's going to be the issue that we already learned this time.
Sir, excellent. Sir, how you can see the future of this metabolic surgery, especially in coming this decade or till 2030, how you can see the role, especially role of metabolic surgery for the treatment of real pandemic, that is diabetes?
I think, as I told you at the beginning, the metabolic surgery itself, we have to join still to bariatric surgery because, there are so huge number of population that we are dealing with this pandemic that we have to be aware of that. I think metabolic surgery is going to be a huge future in the near future, in the future. But we have to be aware we have to combine this surgical approach with the medication that is coming. So we have to get an agreement with, endocrinologists and diabetologists in terms of getting, the most important care of our patient, right?
Yeah.
So it's going to be the future, going to be a very important future, but we have to be aware of the new scenario about our endocrinologists, our colleagues.
Sir, I agree with you. So one of the concern of, unfortunately, our endocrinologist is this. So when patient will do surgery, what will happen to this patient and the follow-up? And I think this is a teamwork, and this is as you have mentioned, so this is a team. So if we go together with the team and they refer patients to us, then we can help these patients positively, and this follow-up will be also by our endocrinologist. There is no issue. But I think need to think combine. I have no idea, a society. And another thing that we expect, especially from your side, persons like you, to make some guidelines for this metabolic surgery in low BMI, because now for bariatric surgery, there is a lot of work and there are different platforms like IFSO, SMBS, and many, many others. But in my opinion, still this metabolic surgery in low BMI, again, I am asking in low BMI, so need to improve, need some guidelines, need a structure.
I agree, but the most important thing, in these new guidelines, for sure, we will not be the only protagonism, we as surgeons. There are another protagonism in terms of, building up these new guidelines. This is the reason because medication can help the patient before surgery and after surgery. So we have to implement and to be aware, it's going to be a long, long, long way to accept that, surgery can improve type 2 diabetes. Don't kill, this option, saying that this is only our patients and there is no way for medication. This is a huge mistake, in my humble opinion. Okay, so it's going to be very important. Regarding, to take into account this. So this guideline has to be built up together with the agreement, with the, the consensus of some other, not only we as surgeons say, we can operate this kind of thing. Because in the end, the majority of patients will we have under the umbrella of endocrinologists, except mouth by mouth, the patient can go for metabolic surgery.
Sir, definite. We need MDT and practically MDT, not only on the paper, practically MDT. And this collaboration with endocrinologist is definite, very important. Because, and also in my opinion, nephrologist, because if patient is suffering with nephropathy, we also need ophthalmologist because
no endocrinologist. I mean, a non-surgical guy, nephrologist, cardiologist, traumatologist, there are many, many people involved in that. But, in the end, we must not be alone.
Yeah, definite, sir. Sir, really, it was a great session, and personally, I have learned a lot because at our this platform we have a lot of newcomers. They follow our interviews. If you have any message for our youngsters, they are just now going to start metabolic surgery.
Well, my most important message for them, going to be, don't work alone. Work in within a team. The multidisciplinary team is essential for dealing with this kind of challenging patient. Don't work alone. Work with the endocrinologists, with nutritionists, with psychologists, with other surgeons. Don't run this way alone.
Sir, so much thanks. And you are really always supportive, you are encouraging, and definitely you are a role model, especially in bariatric metabolic field. Personally, long time I know you, and also I aware about your positive role in promotion of education, especially in bariatric surgery. It was great opportunity for me and also for GLR team. Sir, so much thanks, and in future also we need your support.
Okay, thank you so much for having me there. And Dr. Inram, and my pleasure of being here. I hope to see you very soon, face to face.
Sure, sir, and a great honor, and so much thanks, my viewers. And this all interview series is due to your follow-up, your support. If you have any question, you can ask in comments, and Professor will respond next week, Tuesday evening. This time 10 p.m. Dubai time, we will be with another legendary surgeon. Sir, so much thanks, and have a nice time.
Have a nice evening. Bye-bye.
Thank you, sir.